Thank you all for being with us for the June 16th commission briefing. Do any commissioners have any questions about any items on the agenda? Okay. Are there any other items that commissioners would want to add to the discussion today? All right.
Mr. Chairman?
Yes, sir.
When you ask questions, are you talking about tonight's agenda or this agenda here?
Good question. Thanks. I was referring to this meeting.
This meeting.
Yeah.
Okay. So, but I think that when we get down to the COVID-19 discussion, could we reserve the fact that maybe we need to extend that to the regular meeting if we have to?
So you're interested in adding a new agenda item to the 5 p.m. meeting today?
Yes, sir. If when we get down to this COVID-19 discussion, there might come something come up that we might need to move into the.
Okay. Why don't we talk about that when we get to it here, and then we'll see if there's agreement. It would take a consensus to add any additional items to the agenda for this evening.
Okay. Thank you.
All right.
Brony, I'd like to just add a very quick update around an NCACC opioid litigation working group I've been sitting on, just to kind of share a quick status update.
Okay. Great. All right. Very good. So let's go ahead and move on. The first item on our agenda is an update from the United States Forest Service about their proposed forest plan revision, and we have Alice Cohen and I think other members of her team with us, and they'll be joining us via Zoom. Thanks for being with us.
Thanks for having me. Can you hear me now?
Yes.
And can you see all three of our pictures then?
Yes.
Okay. Well, then I'd like to introduce our district rangers that are involved with managing parts of Buncombe County, our Forest Service lands in Buncombe County. On top, you have Karen Sanchez-Medor, who is acting district ranger for the Appalachian District, and Dave Casey is our district ranger for the Pisgah District. So they have joined us, and if we have some questions, they may be able to answer some questions, and they also wanted to hear what your input is and your feedback. So at this time, I'll go ahead and share my screen, and let's see. See if that works. And if you will let me know if you can see my PowerPoint at this point.
Yes.
Okay, great. So I'm Alice Cohen, Collaboration Specialist for the National Forest in North Carolina. And as you are aware, the National Forest in North Carolina have been revising their comprehensive land management plan for the Nantahala and Pisgah National Forest. And we extended our original 90-day comment period by an additional 45 days to account for the disruptions caused by COVID-19 pandemic. And so the comment period now ends on June 29th. So just as some quick context, the Nantahala and Pisgah National Forests are among the most visited in the National Forest System, with nationally recognized scenic and recreation destinations that are among the region's greatest economic assets. The two forests include approximately 1.1 million acres scattered across the 18 westernmost counties. The plan provides a framework to guide future management of the forest, taking into account environmental, economic, and social impacts of activities. And the plan recognizes the multiple uses of the Forest Service mission, as you see on the slide here. Places matter. To better reflect what we heard are the values and important places across the forest, we added geographic areas. So geographic areas are many chapters that include a description of restoration and sustainable recreation opportunities, the connections the local communities have to those areas, and opportunities to partner with others to get more done, and lists of places and uses that are important to those areas. To assure consistency with local and comprehensive plans, we reviewed 94 county, city, town, and regional plans. And common themes and concerns included economics related to public lands and their values, recreation references, greenways and other outdoor recreation opportunities, cultural and heritage values, Forest Service works to preserve these values: protection of natural resources, air quality, soils, erosion concerns, water quality, etc., and prevention of natural hazards such as flooding and erosion, landslides, those things that we experience in this region. Additional themes included protection such as scenery, aesthetics, ridge lines, and also growth management. And we listened over the past several years. We've held 48 public meetings, nearly 50 at this point. We reached out to all 18 counties and had focus meetings with 16 of them, with additional meetings scheduled. We last were able to meet with Buncombe County, with your county, in February of this year. Some of your staff and commissioners were represented there. We met with 3 regional councils of government, local congressional staff, tribes, scientists, interest groups, and youth. And we've been heavily involved in 3 collaborative groups working towards shared goals for the future of our forests. We've received an unprecedented amount of public comments and have incorporated numerous innovative management approaches in our draft plan. Using public input, we've rewritten parts of the plan, changed management area boundaries, added a new chapter about places and uses on each part of the forest. We added and analyzed for a second tier of objectives we may be able to accomplish through partnerships and other outside resources. Our goal really is a broadly supported and fully implementable plan. So we recognize counties are concerned about their economic health, and all action alternatives include the following contributions to local economies. We currently average approximately 800 acres of timber harvest per year, and we're proposing 1,600 to 3,800 acres harvested per year over the life of the plan. And this goal is supported by timber interests and environmental interests alike through these collaborative processes that I've referenced. We're one of the most visited national forests in the nation, and we propose increasing sustainability of our recreation opportunities, along with increasing the quality of those experiences. And the proposed plan includes improved forest road conditions and increased access to the forest, which we've heard a lot about over these past years of public involvement. And all of this leads to increased jobs and income across the area. So we are in the process now. We have gone through the assessment, public input, drafting the plans, and now we're at public review. So the plan revision process has these multiple steps and a greater than ever emphasis on collaboration under the new Forest Service Plan revision guidance. So the first steps are to determine the current status of the resources, identify the issues and needs, and collaborate, which we have done. So we've drafted a forest plan with multiple approaches or alternatives to implementing that plan. And the alternatives examine different ways that management can make progress toward multiple goals and be sensitive to special places. The Forest Service does not have a preferred alternative because we want to hear from you before we make that decision. This is something unique. Usually we come out with a preferred alternative, and we recognize there were some areas that we really wanted more input on, so we have not chosen a preferred alternative. We built the alternatives based upon what we heard were shared values to offer win-win solutions and minimize polarization. And then we are required to analyze how those alternatives affect all the resources. It's an incredibly complex process. We released the draft plan, environmental analysis, and maps in mid-February, kicking off the formal comment period. As previously mentioned, we've now extended the comment period to June 29th. And this extension allows us to adjust our approach to reaching our rural communities and allows interested groups and individuals to review the drafts and offer comments back to us. So there are numerous references we've created to help folks navigate through what we have proposed. So please see our website for our virtual open house, including informative and interactive materials from videos to maps to information on your county and areas of interest. I hope you're able to join some of our public question and answer conference calls along with our virtual open house website. We have these conference calls especially in the interest of folks who don't have as much connectivity or other resources to manage Zoom or other format of public meeting in these days. So for an overview, I recommend you see our reader's guide, view our 2-story maps, look at our consolidated objectives, and for Buncombe County specifically, look at North Slope, Pisgah Ledge, and Black Mountains geographic areas, mini chapters. So that was my real quick overview for you. The revised plan will increase the pace and scale of restoration. It will help generate more jobs and economic development in local communities, and will promote sustainable use and enjoyment of our national forest. So we hope you'll help us engage your county and communities, and we have the opportunity to create healthy, resilient forests for the future. Here's my contact information, here's our website, and at this point, I will see if I can stop sharing and slideshow. So let's see. I can bring this back up. So at this time, are there any questions? I'm not able to see my screen, so let's see if I can do something. Okay, so we're back. I don't know how many minutes I took, but hopefully there's time for a question or two if anyone has questions.
Thank you so much, Alice. That was a very informative presentation. We appreciate the Forest Service taking time to reach out to the Buncombe County and the other counties in Western North Carolina to ask for input on this important long-range forest plan. Commissioners, are there any questions at this time?
Information. I appreciate her bringing it to us today.
I would just add maybe more of a comment than a question. Of course, you know, one of the areas that is of particular interest to the commission and many of our constituents in Buncombe County, of course, is the Big Ivy area. And the county commission did prepare a resolution regarding management of that area. So we did discuss that at a recent meeting and adopted that resolution unanimously. And I believe that's been forwarded to the Forest Service. But if we need to resubmit that formally as part of the public comment period, just let us know, and we'd be happy to do that. But we love Pisgah National Forest, and it's one of Buncombe County's greatest assets. So we appreciate all your great work and stewardship of these public lands.
Thank you so much. And yes, please do use our website link to submit formal comments. We really do prefer you use our online system because it helps us to organize and coordinate and put all what we expect to be many comments into some kind of order. So that would be great. Thank you so much.
All right. Well, Alice, thank you. And to the district rangers, we appreciate you as well. Thank you for being with us.
Yes, sir.
Great. Thank you. Take care. You're welcome. Thank you. Bye.
Bye-bye. All right. The next item on the agenda is the Community Paramedicine Program and Dogwood Grant. And Taylor Jones and Stony Blevins are going to help us out with this item.
Good afternoon, Commissioners. How y'all doing?
Good.
Good, thank you.
So I'm very happy to bring this good news to us today. When I first was introduced to most of the commissioners, one of the things that I had engagement with some of y'all is about a need for a community paramedic program. So I'm excited today to tell you this good news that Dogwood Trust has funded us a grant award of $382,000. Next slide.
real money.
So this grant award is awarded to emergency services for a year, a long period with a possible reapply based on our data for funding for a second year. And it's going to be results driven based on evidence-based medicine and correct patient practices that improve the performance of the care to our community. So this will be a tracked by our performance management team here at the county. Next slide, please. So our grant goals is really aligned with what the commissioners brought to the table in the past with the opioid crisis and the high mortality rate there. So one of our goals is to see if we can drop the overdose death rate here in Buncombe County. We want to provide greater access to medication for assisted treatment with people with addiction issues so that we can provide that just-in-time service when it's needed to work with the drug-addicted population to see what we can do to get them into rehab programs. We're going to look at the overall impact of opioids and infections, infectious diseases in our community, and how we can impact those as far as decreasing our hospital ER population, therefore providing quicker emergency medical care to our citizens in the community. And we also want to decrease our 911 dispatch calls to chronic disease manifestation problems and behavioral health emergencies, and actually connect those people with the services that they need instead of trying to take them to the emergency room and then having to build access there. So one of the things that I feel like this program is going to have a tremendous effect on is decreasing cost to our citizens for access of quality health care. So that's going to be a really great goal to accomplish. Next slide, please. So we're going to provide enhanced community paramedics, specially trained, that will provide a high level of care to our citizens during times of overdoses, mental health crisis. We provide naloxone kits to folks so that they can receive Narcan post-resuscitation, so that if they repeat prior to we can get them into a drug addiction program, that there's that life-saving drug there. We're going to partner with our community with chronic disease management processes within different healthcare facilities, partnering with our public health agency, especially with Stoney and his group, for things like wound care, infectious disease, heart disease, and behavioral health issues, of being able to provide that direct care. So that connection with someone who may have a hearing problem, and when they were discharged from the emergency department didn't understand their discharge instructions, and we get them with someone that can help them with their hearing problem, and then give them better education, on how they can provide better access to health care for that individual. We want to provide rapid response medical clearance for those wishing to get in substance abuse and detox programs, especially with some of our underprivileged population, being able to do that immediately instead of working through a crowded, beaten down system that you see in the emergency rooms, be able to provide that one-on-one. And that, in the past, has really been the success of the community paramedic program, is giving folks that one-on-one attention that they really can make a difference, kind of being their coach for better health care. So we've aligned this program, if we go to the next slide here, with another grant, and with the post-overdose response team, the PORT team. I think y'all approved that grant back several months through public health. So one of our paramedics, we will provide 24-hour, 365 days access to our community to 3 full-time employees. But one of these employees will actually be offset by this grant through the PORT program, a federal grant that will provide the 8 to 5 coverage, and we'll charge back to that grant the hours to make this thing whole so that we can provide 24-hour coverage. And with that, we work with a behavioral health navigator to provide those enhanced services to our patients that way also. So the next slide. So the overall grant was $382,000, and again, I want to thank the Dogwood Trust Foundation for providing us with those funds. Buncombe County EMS will provide in-kind support of $15,400, and those dollars will be $10,400 for supervisor that we normally have on shift that would actually provide supervision and oversight. And then the vehicle maintenance that would be required with oil changes, gasoline, all the things to keep us rolling. So the other dollars from Dogwood would be the $6,500 for telephone, radio, and computer communications, program promotion as far as advertising in our community and getting the word out. We're working with our physicians and health cares and putting pamphlets and doing education. And then the $5,500 for continuing education for our community paramedics. And then there will be a cost of a vehicle of about $40,000 and a cardiac monitor defibrillator capability of $39,500. So that's kind of an overview of our cost. If we can go to the next slide. So 80% of this cost will be covered through the Dogwood for the 3 enhanced paramedics, what we call community paramedics. And then the port grant will actually take up the remaining 20%. So there will be no cost to the taxpayers or any budget requests that we're making to the commission today with this. So you might say, what are our next steps? So our next steps would be to actually accept the grant. We'll bring it back and forth during a full meeting on July 21st and make an amendment to our budget for $382,000 for the alignment of the grant, and the 3 positions would have to be allocated at that time. We would come back again in January of 2021 to give you an overview of the program. And at that time, I'm very confident that we'll be talking about the successes of the program and how much of an impact we've made to the community. Do you have any questions?
Just a quick one. First, this is just such exciting news. I think we've been talking about community paramedic program for a couple years, and it's just tremendous to have this external funding coming in, but also the scope of it. I just had a quick question. I think I might have just I just want to make sure I'm understanding. Would they only be responding to overdose calls, and then if an individual also has other chronic health conditions such as diabetes, et cetera, they'd be able to offer care in that context? Or are they also providing response to people who may frequently call 911 because of chronic health-related crises?
So our top priorities are going to be opioid crisis intervention, drug addiction, and behavioral health.
Okay.
But what we find is a lot of people also have these comorbidity issues,
Right.
Like we're seeing in COVID. And so we want to address those at the time and get people on the right track. Because a lot of times it's that overlapping issues that cause the problems too.
Great. Thank you so much. I really appreciate it.
Thank y'all. Thank you so much. Any other questions?
Taylor, where are they going to be stationed out of?
We are going to station them out of the headquarters station here at 35 Woodfin.
Okay. So the other paramedics that are on these ambulances, they'll be coming as well to overdoses or?
Yes, there'll be a dual response to that overdose, and then, once that resuscitation phase, if they refuse transport, then that specialist would take over and provide that ongoing care.
Okay. All right.
And then for like mental health patients, instead of using an ambulance to tie up to transport somebody and a long delay in that process, maybe we're going to work with our mental health specialists to actually get them to the point of care so a transport doesn't have to be made.
Okay. I like the program, and I hope that when the grant's over, that this county's in a position where we can continue something and we can actually spread it out, because it's a long way from 35 Woodfin to Broad River. So if we can put them out in parts of the county to help with this, this is a good start, and I just hope that we can continue this after this grant runs out, or it's good enough that they continue, and we look to expand this program. So, thank you.
Thank y'all.
All right, great. Thank you so much.
Thank y'all so much.
All right, the next item on the agenda is Town of Weaverville Collection Agreement, and Jennifer Pike's going to present this item.
Is that working now?
It doesn't look like it is. If not, you might have to look up there, sorry.
That's okay. Will you advance for me?
I can advance.
Thank you, Chairman. Good afternoon, Commissioners.
Good afternoon.
Before you today for a preliminary discussion on the possibility of a new property tax collection agreement with the town of Weaverville. I'd like to start with a recap of the current agreements we have in place. We have active collection agreements with the City of Asheville, the Town of Black Mountain, the Town of Montreat, and the Town of Woodfin to bill and collect regular property taxes in exchange for a collection fee. These agreements were updated beginning fiscal 2020, so these were new agreements in this fiscal year, or updated, I should say. Next slide, Max. We did send a proposal to the town of Weaverville that contained the same elements as the agreements we have in place, such as a 3-year term. The billing frequency is monthly, and that refers to when we expect revenue from the municipality for collections, and that is based on the amount we collect for the smaller municipalities. Gap billing is included when the county does go forward with that. A special assessment billing structure is included. If you're not familiar with that, those are related to specific properties that may benefit from an enhancement, such as a lighting project or a sidewalk project. Next slide, please, Max. So this is just an overview of the collection agreements in place, including the proposal we sent to the town of Weaverville. The percent of collections is 2% for all the municipalities that follow a percent of collections. The City of Asheville is the only municipality that has a flat rate. There is an increase with that agreement of 2.5% per year for the duration of their agreement. The data you'll see in this figure is related to fiscal year 2019 because that's the most current complete year we have. And fiscal 20 is a little bit different. So I'm hoping we're going to be back on track in the coming year, so that's why this data is presented. Next slide, please. So the benefits of a collection agreement with the town of Weaverville, I view these as a simplified billing for Weaverville property owners. Instead of receiving a property tax bill from the county and a property tax bill from the town, they would receive one bill just like the other municipalities do. Additionally, there would be no additional staff needed in Buncombe County tax collections. We would just continue collecting as we have. The revenue received from Weaverville will offset any additional expenses we incur. Those are often secondary billings or additional letters, things such as credit card fees, like that. I've estimated the county revenue based on fiscal year 2020 for the town of Weaverville value at $64,000. I'm happy to answer any questions you may have for me at this time. Again, this is just a preliminary discussion. There are still conversations going on, but we wanted to make you aware that a proposal was sent to the town.
Great, thank you, Jennifer. Any questions? So, and Weaverville's still thinking this through?
Yes, we've got some questions that are going back and forth, some clarifications, so we're working through those currently.
Okay, great, very good.
Thank you.
All right, thank you. All right, next up is the FY 2021 fee schedule, and Jennifer Barnett will present this item.
Good afternoon, Chairman and Commissioners. In the fall of last year, we brought to you for review and approval the fiscal year 20 county-wide fee schedule. So the fee schedules for all departments across the county. Our goal has been to bring any recommended fee schedule changes to you in preparation to adopt the fee schedule in alignment with the annual budget adoption process. The intent of today is to make you aware and answer any questions that you have related to recommended changes for departmental fees. These are outlined in the summary documents provided. Max. The departments in which have proposed changes since the last approval of the fee schedule include Health and Human Services Clinical Services, Detention Center, Emergency Services, Library, and Planning. Each of the departments are represented here and are available to answer any questions that you may have either around specific fees that are proposed for change, or if your preference is each of the departments could go through the detail of those summary changes. At the time of budget adoption, you will see language in the annual budget ordinance that requests your approval of the fiscal year 2021 fee schedule, assuming we have satisfactorily addressed any questions for requested changes from you. So do you have a preference that you would like to hear from all departments with the summary, or would you want to go for specific questions?
Commissioners, any feedback? I mean, it's we've got all the data here, so I mean, I think we can kind of look at it and just maybe I don't feel like you need to read all this to us. So if there's commissioners, does anybody have any questions, or does anything stand out? Or staff, are there any particular things you'd call our attention to? A lot of these are fairly minor adjustments.
So perhaps the new changes. So I do believe that all of Health and Human Services are specific, pretty straightforward changes. Detention Center and Library was pretty straightforward. So I would imagine that Emergency Services and Planning would probably be two that you'd like to hear from.
That sounds good.
Yeah, I would want to hear on the planning. That would be one on my list. So.
All right, I'll turn it over to Nate Pennington to answer.
Great.
Pardon me. Good afternoon, Chair, Commissioners, and staff. I can go through individually or answer individual questions. The preference is up to you.
I'd go through them individually.
Sure.
I don't have that pulled up, so it's pretty hard. I mean, I can see it, but just go through it real quick.
Sure, absolutely. We've been running across a lot of public hearing cases that have asked for continuances. When they do that, it requires us to re-advertise and also send out mailings. We do a 1,000-foot radius. Those add up very quickly. This is a fee change to cost recovery, the expense of having to do the legal advertisement and the changes for the postage, the charge for the postage. For new junkyards that are being established, we never had a fee. This is a way to capture that. There's a lot of staff work that has to go into compliance of those and inspections. We made a small change to some existing fees for manufactured home permits to make it more equitable for smaller manufactured home permits, and that way it's just a base charge with a $10 per space amount rather than just an outright flat fee. We ran into issues where we were having to go out to sites multiple times where they had failed an inspection. There was just some base fees to recoup those charges. Street addressing, a minor change to put that in line with zoning determination letters. We get a lot of requests from mortgage companies. subdivision application review fees for the renewals of guarantees of improvements. These are large-scale subdivisions that put up guarantees of improvements and take years to build out. When we renew either like a bond or a letter of credit, we do extensive work with banks and insurance companies. This is a way to recoup some of the amount of time that staff spends on those. And the last one is establishing a fee for short-term rentals, campgrounds, RVs, vacation rental complexes, and bed and breakfasts. And it's variable depending on the size of each of those establishments. And the reason we did that is to recoup the amount of time that we spend and to document each of those uses. And that's the summary.
So, Nick, can you give just an overview real quick on, what the planning department does as far as measuring customer service it should be giving when it comes to inspections and on-time inspections? And I know that if something's turned down and you got to go back, you're going to charge addition. But can you just speak to how the county? I mean, I'm not getting any complaints. I'm not hearing anything like that. So that question's not coming from that. So I'd just like to know from a customer service standpoint for home inspections, builders, developers, and so on. Could you speak to that just a minute?
Sure.
Since you got the floor.
We have the fee schedule in place to recoup the cost, of course, of the amount of time that staff spends to issue permits, complete the required inspections, work with our permits and inspections department. And then we have a number of quality control mechanisms in place with our Excel permitting software. Other than a specific customer service question that you might have, I think there are a number of safeguards in place and a number of portals in which people may comment about how they feel about our process or any changes that need to be made. I will say that we have seen sort of a COVID-related uptick in the amount of complaints we get for the simple reason that a lot of folks are just locked up at home.
They're tore up.
And we are spending a lot of time looking into any number of complaints, and those can take a lot of staff time.
Sure.
And we address every single one of them with a phone call, an email. We always follow up.
All right, thank you.
All right, thanks, Nate. And did we say emergency services? We would touch on that too. Those are some of the more substantive changes too.
Good evening.
Good evening.
Let me get back to our slides. So I think this, right, okay. So you just go through those charges there. All right. So what we're recommending is kind of in alignment with recommended practice from our billing company. Also what we see across the industry is a standard of double the Medicare allowable rates. And so if you look, the different classifications based off of care provided. And so there's two non-emergent charges, ALS or advanced life support and basic life support. These would be the non-emergent scheduled type transports between home and doctor's office, home to a SOLA center, things like that. So it's not an acute care type situation. Then our actual emergent transports for BLS, that would be for like a simple fracture, simple scrapes and bruises, bleeding control, some basic level care. No advanced level care is needed for those. The first ALS charge, the ALS-1 emergent, this is when things like chest pain, shortness of breath, paramedic level skills, IVs, medications, things like this are taken care, more advanced care is being provided by the EMS providers themselves. And the ALS-2, that has a higher charge rate. These are the more complex calls, and so this would be like a cardiac arrest, advanced airway procedures, severe trauma patient, where we're having to do a lot of interventions and care at a much higher level and a much higher cost overall to provide that. And then the one new charge that we're asking for is a specialty care charge or specialty care transport. The Office of EMS realigned some of the procedures and medications that we give last year, and they now qualify as a specialty care transport by Medicare and Medicaid standards. And these are, again, more advanced. So these are things like what we call a rapid sequence intubation, where we actually will paralyze and sedate a patient to establish an airway. give advanced medications for pain and things like that. Again, these higher procedures have higher costs, and Medicare allows us to be reimbursed at a higher rate. And what we see across the industry is about twice the Medicare rate is the standard recommendation when it comes to billing. And this helps offset the contractual allowances we have to give to Medicare and Medicaid patients. One thing to remember with these charges is they do not affect those patients. So Medicare and Medicaid, we have a set rates that we have to accept. It's about just under $3 million a year we take in contractual allowances for those patients, and they represent about 48% of our patient population. These rates are mainly going to be covered by private insurances, and we estimate about $139,000 additional dollars. That's what our billing service is estimated for our increased revenues by accepting these rates. And when we looked across the region, the state, at like services, with these pretty much line up with what most services are charging. We looked at Mecklenburg, New Hanover, Guilford County, Haywood County, all have adopted this twice the Medicare allowable rates as the standard. It's what we see kind of across the board with that. So this is our transport charges, and also increasing our mileage from $10 a mile to just over $15 a mile. And our average transport is about 6 miles when we look at our data for that.
So that's a big jump on the mileage. I mean, when I look at a couple things jump out at me, and I don't know, I know nothing about this, so to go up from $10 a mile to $15 a mile, is it just from your estimates that, you said you're talking about Mecklenburg and these other counties? Is that where you're getting that from?
Again, it's based off of the Medicare allowables. So Medicare allowable is about $7.50 per mile, and we double that to get to that $15 per mile chart. That's how that is based off of. Well, it's meant to offset the wear and tear and service and maintenance of vehicles, and we know that with the changes in standards, that our vehicle costs have gone up about $80,000 a unit from what we've paid in the past. So when we start replacing fleets in the coming years, we're going to see those costs increase. This is one way we offset that to meet the standard that's set by the industry. We'll have to offset those costs somehow, either through revenues for the people using the service, or through a tax base, and through the general fund. Again, even with the mileage, we only can charge Medicare and Medicaid patients what's allowable. So we have to write that much off. And it's the private insurances that helps offset those write-offs that we have to take. Either across healthcare, this is a standard practice for doctors' offices, hospitals, specialists to practice this way to help balance things out when it comes to final end of the day business.
Okay, thanks.
All right.
Hey, Jamie?
Yes, sir.
I know these are the Buncombe County EMS rates,
Yes, sir.
but does the Buncombe County Rescue Squad and the fire departments, do we know if they follow these kind of same rates, or is there significant difference in being transported by one than the other?
Right. So generally what we've seen in the other rates when we've looked at those is they tend to align with us and keep it similar. There is some slight variances based off their recommendations from their billing companies. Some of them use different services than we do. But again, our billing company, which I think there's 2 of the other transport services that use them, they highly recommend that twice the Medicare allowable rates.
And do we share these with those people as well to give them an idea that, hey, let's be uniformity across the entire county?
I believe it's been talked in the past. And we can share this with them. This is what we're moving towards, so they can also align closer to that and keep it consistent across the county. Okay. And also will help them in their services also.
Thank you.
And then the other increases we're asking for is for our standby services. And so these are special events that we cover, so races, mass gatherings, soccer games. So we provide medical coverage to these events, either based off of their type of event they're holding, if the permit requires medical coverage, or if their insurance carrier requires medical coverage. And we rely on overtime costs to cover these events. And so as costs increase, we've never really increased these costs in 8 years. And so trying to more align so we recoup that overtime cost for our crews covering these outside events of normal 911. These are paid by the event coordinators that hold the event.
Do you have a ballpark estimate of how much additional revenue these changes will generate?
Of these, we were hoping to estimate off of this year's events that but all those got
I'm talking
canceled.
about all of the changes.
All the changes. So our billing company estimates for this increase anywhere from $139,000 to $190,000 additional revenue over the next year, based off of our prior year performances that we've seen with our account with them. That estimate was made before COVID, so that may be actually lower initially, but moving forward, we should see that type of response from our billing company.
Okay. Any other questions, commissioners? All right.
Thank
All
you.
right. Thank you so much. Appreciate it.
Mr. Chairman, I don't have a question for emergency services other than, it's a fire marshal question. The fire marshal site time, is that $50 an hour to do building inspections? Is that what that is?
Commissioner, that's to align with fireworks, like standbys for fireworks, for the demonstrations, for those type of things where they're asked to come in and do extra duty. Okay.
And for these fee changes, when we adopt the budget, they'll be automatically adopted as part of it unless we make any changes. Great. Thank you so much. All right, commissioners. Next up is a COVID-19 update, and we have Dr. Mullendor and Fletch Tove with us.
Good afternoon.
Good afternoon.
Max, if you want to pull up that dashboard. Cool. All right, so I'll start out just showing this is today's dashboard where we're at. So you can see we're at 457 cases today. 148 of those individuals are in isolation at this time. We are at 36 deaths, 31 of which have occurred in long-term care facilities. The age range, in the predominant age range, 40% of our cases are in the 25 to 49-year-olds and 26% in the 65 and older. And still seeing the disproportionate impact on the Hispanic, Latinx population and the Black, Indigenous, and people of color. We remain at 5 outbreaks in long-term care facilities, which means 2 or more cases in residents or staff. And that's impacting 92 residents and 70 staff across those 5 facilities. And in terms of the number of tests, that continues to increase, over 12,100 tests. And so when you do the back of the envelope math, 3.8% positivity rate. So it's kind of hovering up there around 4%, I would say, for the past couple of weeks. And then in terms of community testing, I just want to talk a little bit about that. So through the end of last week, we had been at 11 sites and done 751 tests. Really good turnout last week, about 100 at each of those 3 sites. So far, 24 positive cases have come out of that, with some tests still pending from last Thursday's test. At last check, about 27 tests still pending. So just wanted to give you that update. We're definitely seeing more community spread, cases being identified that are not connected with the long-term care facilities, people going, mass gatherings in terms of churches, in terms of going to the beach with family, in terms of cookouts, parties, work. So it's definitely impacting all sort of sectors. So I just remind people about the importance of the face coverings and the social distancing and hand washing. In terms of the main thing I came to talk to you about today is the long-term care facilities and the proposal that was shared with you last week. The number one need we're having right now is in those facilities where we have a case and the guidance is to test all residents and all staff. Testing the residents, not an issue. Those residents have insurance that is paying for that testing. Where we're hitting the wall is the staff insurance, where we have some staff who don't have insurance. We have some staff where their insurance plan is paid for a couple rounds of testing and then says no more. And then some health plans that are just saying it has to be ordered by their primary care provider. And so we're hitting this wall where we're having to do workarounds to get the testing done. And so wanted to see if we can help support that testing, because it's really important in order to contain and stop the spread and hopefully end the outbreak. So we have a model currently that's working really well in some facilities that have used it. It's Mako Medical Labs out of Henderson, Raleigh, North Carolina, sometimes partnering with Range Urgent Care to do the actual specimen collection, and then those labs are run at their, the tests are processed at their lab. Most tests, if I went to my doctor to get tested, it would be about $100 a test. That's the Medicare allowable rate, and so that's what everybody's pretty much charging. This lab has decreased that cost, so they're offering it $75 a test, and they actually would offer it at $72.50 a test if there was a prepayment, so if they got paid in advance for a set number of tests. The process is working really smoothly in terms of turnaround time, 48 hours. Labs are processed without issue and getting back to the facilities and helping us quickly, in the facilities, quickly identify new cases so that they can be isolated and cohorted. So right now, our workaround involves state lab and Range essentially doing the specimen collection for free, which is a gracious thing that they've offered, but not necessarily sustainable for them. So that's our number one need and what I'd love to get some discussion about today.
So $72.50 each per test. How many staff and patients in all the long-term care in Buncombe County?
And let me clarify. So when we're talking about this, we're focused on the staff, because again, the employees have they have insurance that can be billed. What we're looking at is sort of payer of last resort, when there is no insurance company to pay for it, when the staff can't afford to pay for their own tests, which most can't. And we're again focused on like facilities where there is an active outbreak. And so the one we're right now really focused on is Aston Park, because that's where we've really hit this issue. And so their staff right now, we're doing about it's under 100, it's about 96, I think, is how many staff they tested this most recent past. And so that's a weekly thing, and until they get to 2 weeks with 2 straight weeks with no new cases, then we can take a step back.
Are you testing, you're testing everybody?
All staff at that facility who have not previously been identified as having COVID-19.
So did you say all staff and not employees? Did I hear you say not?
It's staff, sorry, when I say staff employees, they're interchangeable.
Okay, all right, so
Apologies.
it's non-patients.
Non-patients, because the residents are getting tested, and that's being done through Mako and Range, and that they have a payer source. What we're stuck with is when there is no payer, there's no insurance company to pay the bill.
So what's the total staff in the county?
So the total staff in the county is about, we're guessing 2,400. It's a rough estimate. But again, some facilities have been able to do testing. Some insurance companies are still paying for testing.
So if you had to come up with a number of, those that are the staff across the county that would have a need for testing? Would it be 2,000? Would it be 1,500?
I mean, what I can tell you now is the need we have now, right? Because it's who has an outbreak, who can't pay, and it's the 95 or so employees at Aston Park.
Yeah.
That's where we're at now.
Yeah, that,
But the thing is, I can't tell you that tomorrow facility X wouldn't hit that same wall.
okay, so, it's been on my mind and heart for a while, that, where we have the deaths, it's the only way I know to say it, is in those facilities. It's very vulnerable. The population is very fragile. We all know that. As a commissioner, I'm willing to say that that as a preventative for the entirety of the county, an investment of testing all the staff at every nursing home is a number that I would like to look at and see what that would be. Is it $250,000? Is it $500,000? If that money's set aside, does that put the county in a position where, because, when you talk about community spread, someone in staff has it and they go, and then, their husband or, they work there and they have it and they don't know it, and then they go home to, the husband or wife or whatever, or the family, and then they go. I'm saying things that everybody in the room knows, but if we were going to, make a commitment, I don't know that there would be anybody I don't know that there'd be a lot of opposition to this. And I'll hush and let other commissioners talk. But I'd like to know what those numbers are. And Chairman, to my colleague Commissioner Penland, the reason that he asked that is we just had a discussion about it, and we heard some good news from a friend that's a mutual friend of Robert and I that got some good news from Aston Park, that someone's grandmother and mother that had COVID that was way up in years is recovering. And that's just thank the Lord for that, because that's doesn't happen.
Yeah.
It doesn't happen that much. So anyhow, Chairman, that's one of the discussions we were wanting to have, and if it requires creating a specific amount of money from fund balance or from CARES or a combination of the two, to protect the spread of the virus from those facilities and to protect that vulnerable population, we would like to have that conversation. So I'll leave it at that.
Great.
And thank you, Commissioner Belcher. If I could build on that, thank you first for the presentation. I would love to discuss moving forward with at least one of the options discussed in the memo we received that I think builds on what you're saying, Commissioner Belcher. Option one, basically, in that memo seems to respond to the most pressing need that we have, which is when there is a case and a facility that's prepared to do the testing but is running into barriers, that we would be able to step in and be the payer of last resort. So I would love to, I guess we'd need to do it at our 5 o'clock in order to take, or perhaps would we need to do it? Because you already have allocated money, and I believe we haven't spent close to that. So perhaps we could do this at the level of staff direction.
Correct.
So I'd love to put on the table that we move forward with option one, but also that we continue to look at ways to strategically approach, I think, what Commissioner Belcher is suggesting. It looks like from sort of back of the napkin calculations that if there's 2,400 employees, we could do it for about $70 a test. It would be about $170,000 to do one round. But it's the repetition of rounds, of course, that gets you into the more helpful data. So maybe staff could generate some figures just for us to look at as we move forward about some strategies that might exist around expanding the cohort of long-term care facilities beyond those where there's a known outbreak, and how the county could be supportive in that. So if that, I'd love to just put that on the table for discussion, and maybe other folks can refine that further.
So go ahead.
No, I would just like to see, I understand the most pressing need. From March to May, we did a fantastic job in this county keeping it out of these nursing homes. And for the ones that don't have an outbreak right now, I would like to see what testing would look like, that we test, even if it's not in that nursing home, we test staff some way, somehow, to keep it out of that nursing home.
Yeah, that's what I'm saying.
I want to look at
everybody.
this, and that's the reason I had asked Mr. Chairman. I don't want them to bring something back. I don't know if we need to do it officially in a meeting. I'm ready to quit talking about this,
Right.
and let's protect those long-term care facilities, whether they have an outbreak or there's a potential. I mean, and then, because we know if we kept it out for 2 months, then I the only other way you think it would be gotten in there would maybe somebody from the staff. Bro, I don't know. The investigation may do that. So how do we prevent these other ones that don't have the outbreak right now? And if it means that we need to figure out some way to test them or talk to them, let's just quit talking about it, and let's do something if we have to do it at 5 o'clock.
So
Well, I would. Sorry.
I just have a quick question to tag along with that. I do support moving forward with option one. I am really curious what we know, though, about the facilities that staff have not had any positive cases. What are they doing differently? I know I had to answer some questions to my own HR department with my employer had I attended any mass gatherings over X number of people. Are those employers able to look at that? Can we pinpoint what is happening that is working and not working?
I feel like, they're all, screening and following guidance. I think it really comes down to luck, honestly. The staff are going out in the community, and so it's really about every contact they have. And that's why I heard Secretary Cohen talk about yesterday. She was talking about restaurants, and then she was connecting those to long-term care facility. We have to remember, every one of us, if you just followed all our interactions, potentially it could lead to somebody who's a staff at a long-term care facility. And so I really do, with that level of community spread we have, assuming that all the staff act the same and, when they go home, it's potentially luck.
So, you're fine. Go ahead.
Well, just following up on Commissioner Penland's point, maybe Dr. Mullendore, you could sort of walk us through it. It seems like, I'm sort of referring to the memo, that option one, it sounds like there's readiness to move forward for it.
Can we pull that up? What's that number? I don't have that in front of me, so it's $87,000? 80,000?
It's for Aston Park right now, right?
That's 80,000 just to do Aston? But that's to do it
8,000 a week. It's 7,200, 70.
Oh.
If they have 100 and we do on 7,250, it would be 7,250 a week. And then if they keep identifying, could only go down. Let's put it that way.
So I don't have the memo pulled up. Is that what's in there, Commissioner?
Yep.
Can you forward that to Max if you have it pulled up already?
Yeah, that'd be great.
Yeah, bear with me for 1 second.
Yeah.
So the 80,000 was the remaining staff. What we were looking at in that memo was the skilled nursing, so the nursing homes and the adult care facilities.
Yes.
So we carved out the most fragile population that we have in our county, which was 35 facilities.
Right.
And that's the piece that we were focusing on, not the 200 that is all the facilities that do have some type of senior care. We were only focusing on that really fragile piece. And of those 2,400 or so employees, we believe about 1,300, so we have about 1,000 that has not been tested. To Commissioner Panlin's point, there's 1,000. So that $80,000 that you're talking about is to test, that baseline testing, as we're calling it, for all the employees that, in those skilled nursing facilities that have not yet been tested.
Okay.
That was about 1,000 employees at the $75,000.
Yep.
So that's where we were getting that number from, the 80,000. So that would be to do what you're asking for, that one time case. But when we do that and we do find a positive case, that's when the requirement steps in that we do that continuous testing. So that's the piece that we need help with now at Ashton Park. And we do know, if you look on the state website, they have the highest case count and the highest death in our community. So that's a critical piece for us, and we're asking for that help to help fund them and to do that testing. The model that we have in place is True Range Urgent Care and MACO. MACO says if you do a lump sum upfront prepayment, that they would then come on site and test the employees once a week until that money runs out. So we're at the state yesterday, Secretary Cohen mentioned that the state is also looking at how can they be that payer of last resort. So our hope is that that will be sooner rather than later, and we could be standing in the gap for a short period of time with county funding. That's our hope. And then the state will step in and take over for that testing piece. So if what I'm hearing from you is two things: the 80,000 would be do that point in time tests for all that haven't done it yet, all the facilities, that point in time. But what staff is asking for is we also need a backstop that on continuous ongoing testing at Ashton Park and other facilities, quite honestly, of that 35 that we carved out that currently can't test or continue to test that have an outbreak.
So let me
the piece that
I'm sorry, go ahead.
the piece that I would say is you gave us $1 million for COVID at the early onset, so 500,000. We have a second 500,000 that you gave us. The recommendation from staff is that you continue to tell us staff guidance to go ahead and set that in place, some contract with MACO to do the ongoing testing, and then also to do that point-in-time testing as well with MACO.
So if, whoever needs to answer this, if there was $250,000 allocated, what would we, within the nursing homes, how would we invest that in protecting the nursing homes that we have? I know 80,000 is one. Does that mean we'd do 3 runs? Three tests, or how? If we set aside that much money, what would it be used for? In the nursing homes only?
Nursing homes and adult care homes?
Yes. Yeah.
Okay. So again, it's payer of last resort. So if they have insurance the staff have insurance that pays for it, great. That'll get billed. It's more that if we do this with MACO, they would invoice the county for any staff that didn't have an insurer, that didn't pay. And so it would be those facilities that have outbreaks ongoing who need the weekly testing, and then potentially also for that baseline testing at all, to make sure that every one of those 35 facilities has done at least one round of testing. Again, payer of last resort. If there was no insurance plan that covered the employee testing, then we would get invoiced by MACO,
Okay.
and that would be what that money would be used for.
So I'll tell the commission where I'm at. That's the number that I'm willing to recommend to the board that we use from the from the money that we've set aside to go full on the nursing homes testing, starting with Ashton Park. That would be.
And does that include the ones who haven't been tested? Are we talking about all of them?
Yes. Yes. I think you have to put a hedge around. I think you got to put a hedge around them. If I'm wanting to protect and invest, that money in the county, then I would want to put a hedge around the most vulnerable people in the county and the spread from those areas, too. So if that number's 250, then it's fine. If that number's 300, then I'm okay with it. But so I'll hush. I've thrown it out there. So. Because I can be on this all day if y'all want me to.
Mm-hmm.
No.
All right, so
Commissioner, the other point I do want to put on the table is the conversation around equipment where we can do testing at a cheaper rate in the county. That's something that staff has been looking at. We haven't gotten very far on that. But when you throw that kind of numbers out, that's the money that we're talking about to have equipment in our county.
It's cheaper to do it here.
It's about, and then it will be available in Western North Carolina. It will be faster turnaround than the 48 hours. And so that's one thing that I would like for us to talk about. When you're talking $250,000,
okay.
The estimate of
Great.
the equipment right now is about $350,000 to have equipment set up. That is a longer term solution than what we're talking about right now. But
So
that's I'll let
okay.
Brownie.
So then why are
So,
Then do that. I'm ready to do that.
yeah, I mean, so I'm assuming that we would, will be able to be used for a lot, not only, COVID, but probably other things. Just COVID? Okay, well, then I'm cool with it too. But,
It's gonna be here for a while.
yeah, it is. It is.
We have been working with Dogwood Health on the possibility of them doing something as well as Advent Hospital. Would be the two hospitals that we're looking to figure out how can we have our own testing site in Western North Carolina that we wouldn't have to be talking about how do we get testing for our employees that need
Yeah.
testing.
So let me ask you this. If we had that, does it meet the urgency need? If we had our that? If we invested $350,000 in what you just said, can that be done now?
No, I mean, it's like a 2-3 month.
2 to 3 months out.
Yeah, so we can't wait that
So
long
yeah, we
for-
need,
So we need a stopgap.
yeah.
So we need that stopgap now. But when you were saying 200, 300,000, that number to me means a permanent, long-term solution. What we're asking today is much less than that. How can we be standing in the gap to get that testing done now at a
Yeah.
much smaller price? But if you're willing to go that high, I want you to know that there's a solution for that. That could be longer term
Wow,
in nature.
that's awesome. I mean, this commissioner is, so.
So the stopgap is 80,000. Basically, that's what we're saying.
Well, that's the baseline testing.
Baseline testing.
Then it would be the stopgap is also like the weekly testing at any facility that has an outbreak that doesn't have insurance
Okay,
coverage. Which
that's
could
where we
be-
need, that's where we need to go first, but I also like the
Yeah.
idea of doing we have the equipment to do
Yeah.
the testing. And if that's a 2 months out, then let's start it tomorrow
Yeah.
to see how we can do that. But we just got to take care of these long-term care facilities.
Sure.
So, Commissioners, I think we have, a couple of options procedurally. I hear
Oh, yeah,
a lot
thank
of agreement around a couple of concepts. One is providing financial support if needed to, because there's the responding to facilities that have active outbreaks, right? And doing whatever we can to partner with them and help them manage a really tough situation. So I hear consensus around that. And then the second part is completing a first round of baseline testing for all staff, right? In the 35 facilities, and about half are already done it or have committed to doing it. So there's the other half, and that's $80,000. And I hear a lot of support for that too. Ballpark $80,000.
Yeah, for both.
And then the third piece is the forward-looking preventative strategy. Because while the first round of baseline testing is great, like doing it once is way better than doing it zero. But the reality is that's just a point in time, right? That just means that those staff don't have it right now. But someone goes out to some social gathering or wherever it might be, and they catch this very contagious disease. And it really only takes one staff, right, to get in there and it can spread really fast. So the reality is that if we want to have this as a true prevention strategy, then we need repeated testing on some regularity. And that could become quite resource intensive, quite expensive, depending on whose shoulders this is all falling on. And then there's we can contract with folks to do this, or we can explore this idea that the manager's talking about in terms of actually investing to bring a new COVID-19 testing lab of some fashion to Western North Carolina, which does not currently exist. And there's an upfront capital cost to do that. But if we do that, then that means we may not have to contract, right? Because these are good companies, but they're businesses. They have to make a margin, and it takes time to do that because we're shipping all these out of the region to some other city. So we have this lag time before we get results back. So same-day results testing in Western North Carolina at a much lower cost. So that's the idea of the forward-looking, hey, this is going to be with us for at least another 6 to 9 months, maybe longer, and we're going to need to do tens of thousands of tests, right?
Sure.
So let's plan for how do we do that at scale. So I'm hearing a lot of support for each the immediate things we need to do, and then this idea of feasibility for larger scale Western North Carolina testing. So any kind of we could do a couple of things. It's been a good discussion. We could put this on the agenda to kind of have a resolution affirming this, or if we're in consensus, I think we're all here, our staff are hearing us. So
what
if we're all in agreement on that,
Right.
we could ask if there's guidance to, to move forward on the,
Can we do that on the money?
because we've already appropriated money for COVID-19, so the manager has a pool of funds that could be used for the,
Plus CARES money as well.
the Aston Park and related outbreaks and finishing the baseline testing. And then working on a feasibility plan for larger scale testing. So, manager, do you feel like you have what you need from us, or do we need to put this on the agenda to kind of discuss further at a formal meeting?
Yeah.
So I already have the appropriation. I don't need to appropriate. I can just use the funding that we already have. We already have a budget amendment set
Already
aside for
have
COVID.
funds.
So
I think
my
we got
attorney's
that
telling me I
money.
don't need a motion at 5.
Okay. Jasmine?
Yeah, that's fine.
So the takeaway from this is that with the funds we've already appropriated, the county manager is going to support the completion of baseline testing for all facilities once, and then helping to respond to the outbreaks, the known outbreaks that are currently in the community.
5, yeah.
Right, that's right. And then there's the feasibility for doing more stuff. That's going to take some time, right? Because there's dogwood, there's several. We're going to need partners for that, because this is not, and we can help with resources, but this is not the county's core competency from a technology standpoint and things like that. So, so
Well, I think what we're
do you
doing.
feel like you have what you need, Ms. Pender and Dr. Mullendorf?
Good.
So, and we're okay with not, for our attorneys, we're okay with not to get in your way, Chairman, but I really didn't hear, are we okay with not taking this to the 5 o'clock and voting on, hey, take $80-some thousand of that money and use it for this?
I think so, since it's already been appropriated
It's
by the
already
board for that
appropriated for COVID.
general purpose, COVID-19.
Okay. So just a question on, it's pretty good news for the, I appreciate the conversation, and it's wasn't a real shock to me that the commissioners would feel the way they felt. So how do we get this information to the nursing homes, and when do y'all see coming back to us? I figure you're going to make a call pretty quick.
So I was on a
We
10
didn't
o'clock
know.
call with them this morning, and I told them we had a meeting, and I was hoping to have good news. So
I guarantee
Awesome.
you they
They might be
already know,
watching.
so.
Yeah.
I mean, what obviously I think it goes out saying, and we're saying we pay of last resort on some of these, but we will pay if we need to. But
I'm on that.
I mean, Dogwood has done this great. They're very interested in this. Those conversations are there. I mean, my hope would be that there's a strategy here that both the facilities, local government, charitable institutions kind of together each take on a part, so it's not too heavy for any one of us, right? But if we each play a role, then we can do something pretty bold on this, I think.
Right.
So,
That's the first step. I like it. Thank y'all.
thank you.
Mr. Chairman, can I ask one more question, please?
yes, sir.
And it's based on community testing. Have we done community testing sites in the eastern part of the county? The Black Mountain, Swannanoa, Blarwood?
That was one of the areas that we're currently working on setting up more permanent sites, and we're looking at where, and so yes, the answer is we have not done one, but we're looking at identifying which site for one of the permanent sites. We're going to want to have a north, south, east, west,
Okay.
and a central.
All right, thank you.
Yes.
Dr. Mullendorf, can you share any updates about local hospitalization data?
So the daily reports that I see coming from Mission look like, in terms of those who have positive test results, varying anywhere between, I think today was like 13 or 14 at Mission. It was, I think, as high as like 16 to 18. And then there's always the people under investigation who are getting tested. And so that varies greatly, I think in maybe the 20s to 30s most days. They're, doing in-house testing when they have the reagents to do their testing, which has been an issue. And then they're using LabCorp, and turnaround time looks to be less than 48 hours for that turnaround time. So the data I'm seeing is, what Bill Hathaway has mentioned in prior community updates, that they've seen an increase over the last couple of weeks, but sort of maintaining.
And they still feel like their ICU capacity is sort of adequate
I
to.
mean, that is what he has been saying, yes.
Yeah, because since we're having the discussion, I think, taking a moment to sort of address the state level trends we're seeing that are quite concerning. And what we're seeing locally is it's no coincidence that in early May, our trends went straight like this because we saw a relaxing of so many of the restrictions. So I think we're just sort of living into this very difficult reality that we knew was coming, which was with the easing of restrictions come more cases and come more deaths. And I hope that we can keep front and center kind of the local conversation about how we want to move forward. I know announcements are forthcoming from the governor about phase 2.5 or phase 3 or potential returning to elements of phase 1. And just imagine that we may need to have some local conversations in the weeks ahead about what kind of decisions we make there as well.
Mr. Chairman, Dr. Mullendorf, I want to still talk about the COVID-19, but on another subject. About 5 friends of mine who are hotel owners I've talked to this past week, and I'm sure other commissioners have too. And the concern that they have is, one, the 50% is going fine, but they feel that they're at a disadvantage because it seems that we're the only county in the state at 50%. Everybody else is at 100%. And the other concern they have is that they have things in place from their national chain and all where they can clean the rooms immediately, and they question why do they have to wait 24 hours.
Good afternoon, everyone. So, work backwards through your comment a little bit. The reason for us declaring that 24-hour period initially was out of abundance of caution because we were concerned that people were going to go in, clean the room immediately following occupancy where there could still be, respiratory droplets lingering in the air, and then let it sit for an hour or sit for a day. What we asked them to do is let it sit for a day, then go in and clean it, then turn the room. And the idea was if they were at 50% capacity, they could alternate rooms, so not really losing capacity there, because if you use room A one day, let it sit and clean it, you could use the other room the other day. We're in constant conversations through, Tim Love reaching out to that hotelier group. And from generally what we see from them, even at 50% capacity, they're about 30 to 35% of bookings. We did start the discussion about seeing where the governor goes later in the month, whether we'll take off some of those restrictions, understanding that we are being as one of the few instances where we're more restrictive than the state guidance. But we're having that discussion. We're looking at data. We didn't see, as opposed to several months ago when this initially started, we were very specifically getting our cases from people coming in from out of state. We don't have those specific, it probably is still happening, but we don't have those specific data points to guide decisions on that point. So we're assessing that. We'll have in the upcoming weeks as we transition to whatever our new phase or direction from the governor is, we'll have a good recommendation.
When will that be?
The current order is set to expire June 26th. So there'll need to be, previously as we've transitioned between phases, we get a heads up from the governor, a couple days, the week of. So we're anticipating that again. But we'll look at state trends, we'll look at local trends, and we'll continue having those forums with the hotel groups and lodging groups.
So commissioners, quickly, we don't have another meeting scheduled, so it will be a special call meeting to discuss what trends look like before we move into another phase. So as soon as we hear from the governor, I'll put something out.
Yeah, I mean, I've heard similar things, Commissioner. The one that struck me was the cleaning requirement. I never really thought about it when you presented it out. I'm thinking, okay, we're going to every other room, so you're, kind of picked up on a little bit of the logic there. Part of that concern is the people that actually do that work. Some of those are the people that really need the work and need to go back to work and are and with the requirements that the hotels currently have, their cleaning requirements is probably way beyond what we would even require. So I don't know if there's any flexibility on the cleaning part of it or not, or if we need to, feel like that we need to wait. I I doubt the governor will change guidance on the hotels. If he does anything, I doubt it, because he didn't from the beginning. So, and I don't really have a recommendation other than I kind of feel pretty empathetic on the cleaning part, that might not make a lot of sense, and that we at some point we're going to have to look at probably ticking that up. At 50% is some pretty arbitrary, not really arbitrary, but it's we're probably going to have to look at raising that.
Yes, sir. And so we know at 50% possible capacity, they seem to be at about 30, 35. And so we're asking them, because we're having these constant discussions, if we did 100%, does that, you think you'd be able to double? You go to 60% really? Or would you stay at 30? Because that seems to be the need and the demand. So we're having those discussions. And one of the concerns that community has expressed to us through these town halls is that at 30% or 50% capacity, they only have a fraction of their staff on board. But that doesn't necessarily mean if we give them 100% capacity and they're still only booking 30 or 40%, that doesn't necessarily mean they're going to be able to hire that staff back. But we're having these conversations and looking for solutions. And again, that's one of the single bullet point where we specifically stayed stricter than the state.
Yeah.
And because of the nature of Asheville.
And what I've heard, and I don't know Commissioner Whiteside's, if it's is that if they were allowed to be at 100% right now, that it would be that maybe in the fall, if everything was perfect, they might hit 80 in the fall. It's just not going to happen.
Well, all along, I mean, I think the idea has been, until we went into phase 2, there was no one from outside the region was, allowed to stay in lodging in the county unless they worked for an essential business. Then we opened it up to Western North Carolina. Now we've opened it up to 50%. So, and that idea all along has been that if the numbers can stay good, then it's gonna, that restriction will come off. Of course, we are seeing a lot of bad trends since phase 2 has happened, both locally and across the state. So I'm glad we have some protections there, just because it is so many people like to visit this area, and some of our neighboring states have really high numbers. So I'm looking forward to that restriction being lifted, as long as the numbers, stay manageable. And they've gone up, but we're still, our hospital capacity is good. I mean, I'm optimistic that they can be further. There can be further flexibility in the near future. But I'm glad they're there. I'm glad they're there right now, personally, for myself. Thinking about how phase 2 hasn't gone all great so far for the state as a whole and for Western North Carolina. So.
I think on the long term, I am glad we've exhibited an abundance of caution. I've talked to a number of those same folks as well, and what has really stuck with me is the impact that it's having on people.
Yep,
their
that's right.
employees who, come the end of July, will no longer have the additional, assistance that they need.
Yeah,
And once
that's
that's
right.
gone, if they can't bring them back, what that does for the livelihood of those employees. And for folks who are going to be looking for work, they may leave the jobs that are on hold, further causing additional issues. But I really do worry about the livelihood of those employees who have been furloughed and let go in the meantime, and what that looks like for them, and then what that causes, the ripple effect, the domino effect on our community in terms of supporting them.
And I can tell you, they didn't tell me this, but I know from previous employment, a minimum, they need 60% occupancy just to break even.
So we don't know when the governor's going to issue updated guidance. We know it'll be soon, but we don't know exactly when. So
Yesterday, he said the beginning of next week.
the beginning of next week. Okay.
Yeah,
Well,
beginning
obviously, we want to hear that. We want to hear the statewide strategy. And if we do need to, we're going to talk a little bit later about having another meeting potentially next week for the budget. We haven't decided that yet. But if we need to, we can get together again.
Right.
To, address any local issues that we need to address. So, yes, sir.
Yeah. I guess we all got calls from the different hotels, it sounds like, so I thought this would be something brought up at 5 o'clock instead of now. But we're the only county that's not 100%, right?
I don't know.
Yes.
What I've heard is we're the only county that has restrictions on hotel
Okay.
capacity.
So 99,
No, we have not, that's not verified. I've just heard that through discussion.
I mean, that's what I've heard. We're the only one. So 99 counties have opened the hotels to 100%. So why are we waiting for the governor to lift restrictions, which is going to be on everything except hotels, when Buncombe County is the only one that has got restrictions on it? I've talked to these people, and I agree with our other commissioners here. They got to have 60, 70. It's like they said, they can do 40, 50% during the week, but on weekends, they're capable of doing 95%. And we got to get these people back to work. I mean, so I'd like to sooner than later go ahead and lift this restriction, because the governor's lifted it in 99 counties. And I think it's something we better look at before the next meeting, because July's rolling around. So it sounds like there's enough of us to have opinions on it, and I'd like somehow for it to be put on the agenda tonight, that we all talk about it more.
I just,
Fletcher, you know, obviously the weekends are more popular than the weeks. So when you talk about 30, 35%, is that the average, or?
I don't.
I mean, I guess part of the question is what is just the market doing? Because we can set different limits, but, you know, if people aren't coming, then it's not going to be 100% no matter.
That's
no matter
probably
what
the
we do.
average.
But what is your
35% is the
sense
average
of
from
that?
what I hear.
Yeah, so I don't have the breakdown. I don't know. That's just a
average.
number that Forum has given me, that they're about 30 to 40% capacity. I would like to say real quick that our decision-making process, we're not necessarily waiting just for the governor's guidance. We know there's a delay in our number trends. You know, as we went to phase 1, you know, we had 4 to 6 weeks to see the true impacts of that. Same as when we went to phase 2, 4 to 6 weeks to see the true impact of that. That's that 4 to 6 week window is where we're coming into right now from when we went into phase 2. So it's not just waiting to see what the governor says, it's waiting to give the data trends their full term to kind of see where they go, because we've seen the increasing. It's a slow plateau we're seeing right now. We're just making sure we're not gonna. We have a couple weeks to see whether or not this is something we control or something that's going to run away from us. So we're just giving another week just to see.
Well, let me ask you this, Fletcher, because I think and Dr. Mullendorf, anybody's got insights onto this. I guess one of the questions I have about it is, you know, from the number of cases that are documented in the region, and I realize it's a lagging process, but are we getting more information about the nature of where a lot of the different cases do originate from, right? Like, you know, you talked about funerals, you know, one of the recent meetings, and we do the contact tracing to the extent we can. I mean, I'm all for. I mean, I want, you know, these businesses to get back on their feet as much as anybody. Part of the rationale, I think, for the policies on visitors from outside the region, one is, you know, I think there is some logic to having some space between one person spending the night or a family spending the whole night in a very small room and then someone else immediately coming in, having some space there. There's some good science that indicates that's a good safety protocol. But part of it too is just the sheer number of people who could be coming to Asheville. I mean, we have the highest change from daytime population to nighttime population of any metropolitan area in the state of North Carolina, right? In terms of the number of people who sleep in Buncombe County at night, who actually live here, and then the number of people who the next day at noon are here. It's the highest population change of anywhere in the whole state. So, you know, part of the concern is just the sheer numbers of people coming from outside who could be coming here and helping drive transmission. But do we have data indicating, you know, it is restaurants reopening, it is tourists visiting that are a factor here, or, you know, that's really not. It's really other social spaces that the data is pointing to as a primary driver, because we want to make kind of informed, smart decisions that make the most beneficial impact we can. So what are your observations on that?
So we have to remember that the cases we know about are people who actually live in Buncombe County, right? That if a traveler comes here and then goes home, we might never know about it unless they identify a close contact that lives in Buncombe County, right? And that person ends up, getting tested and coming down positive. Again, what we're seeing with the cases recently are, just people getting back out and doing things that they did pre-COVID, right? Like going to parties, going to the beach, going to work, right? And being with their close, having close contact with others. Anything that puts them in close contact with others. And so I think that's what we're seeing, that as those restrictions were lifted, it's hard for all of us to not want to go back to what life was like before. And so I think...
let me ask this, would it be possible, obviously protecting people's individual, confidentiality, but would it be possible to say that based on what we do know, here's a pie chart, 25% of the cases came from, that we could track down, where we have a pretty high degree of confidence, this person likely got this from this setting, this many were parties, this many were workplace, this many were, were church, this many were some other, how sophisticated is our level of understanding around this, or is it that's just not possible to do at this point?
I would say early on, it's changed, right? The guidance from the state in terms of what information we gather has sort of changed, and so we could look and see how easy it would be to run that sort of report. Versus what would have to be sort of based on our internal tracking. That's, I could look and see. I could see that.
Okay.
That's another question I have. Where are we with tracking in Buncombe County?
You mean contact tracing?
Yeah.
So we were able to obtain 13 of the contact tracers from the Community Care North Carolina. Mm-hmm. We have maxed them out already. This last week, we were able to use them, and we have maxed them out to what is supposed to be their capacity of how many contacts they're supposed to be tracing. So we've put in a request for additional contact tracers, because again, one case could have
many
significant number of contacts. And again, as people get out and about and do more things, they're going to have more contacts, and that's what we're seeing.
Well, and I think to the chairman's point, is that I know there's some things we just can't say. Information that's gathered that is personal and private, and we can't share that. But a lot of what we're hearing is and I'm not saying from you, I'm saying just in general, avoid those gatherings. The things that are common sense, but we don't know that. I'll give you an example. I went for the first time, and I'll try to be very quick. I went Sunday night and visited a church with, most of the commissioners know that, some members of my family actually go out in the ministry and sing. So for the last several months, they've not done that, out of an abundance of caution and the fact of, the churches haven't been open and so on. So we went and visited the church. You would have thought you were going into, the security team at the door checked your temperature. They sprayed your hands. They had on masks. They directed you in your parking on where you went. On the left side of the church, specifically, because I got a copy of it to take to mine and share with others, specifically said if you are at risk, you sit on the left side, and then they put a little parentheses where the piano is, so they made sure everybody knew that side of the church. If you are, healthy, if you had a fever, the security team sent you to the house. Now, I can tell you that it was, just from a personal standpoint and a spiritual standpoint, all of that precaution did not change the experience of worship in that church. Now, they did not allow, they didn't pass a plate. There was all kinds of different things they had done. but they were specific. And so that's one of the reasons that, you know, when I hear it's churches, well, it's gatherings, and a church is a gathering. But it may not be that churches are the issue in Buncombe County, because they were amazing, you know, what they
But
were doing.
it's,
So anyhow,
it's indoor gatherings. It's not.
Yeah, that's
it's-
right.
It's indoor gatherings.
Indoor
It's
gatherings.
Yeah,
whatever,
or
so-
mainly indoor, but again, if you have a barbecue and you have people in your backyard, but you're still standing within 6 feet of somebody for 15 minutes or more, that's a
they
close
could
contact.
get it from you,
Right.
but what?
We need
Yeah,
to-
outdoors,
we need to-
outdoors better, yes.
So,
You're
so
right.
here's what I'd
Wrap
say.
it up.
We need to talk at our meeting tonight about whether we're going to meet next week on the budget. We decided we were going to have a special meeting. There's also been some discussion about perhaps voting tonight. Can we just talk about that for a second? Because depending on partly how that goes, we might know or we're going to have another meeting in the near future. So do commissioners have any, I've heard some folks say, you know, if there's not a lot of questions, then I'll probably want to vote on the budget tonight. If there's a lot of questions, I might want another week to think about it. That's mostly what I've been hearing from folks.
Yeah.
So, does anybody want to make a strong case for something else, or just wait till we have the budget hearing and kind of see how comfortable we are proceeding, or we want to schedule another meeting next week? For the
Isn't deciding the first thing on the agenda tonight,
Deciding what?
if we're gonna have the 23rd meeting? Is it to begin the meeting, or is
On
it?
there?
It's
I thought it
not,
was under the
it's
budget.
actually the action for the budget. After you hear the budget, then you
Okay,
decide
yeah,
about
I
it.
think we need to hear the budget before we decide,
But
and
to
hear the
chair-
comments before we decide about the 23rd,
To
correct?
the chairman's point, if the budget is adopted tonight, the governor intends to come forward with new guidance. Our order does expire on the 26th, so we need to think about what day would we want to do a meeting to talk about what that guidance looks like for the next iteration. Do we scale back, or what does that look like?
Yeah, I mean, we could call a special meeting within 48 hours, right? Not even have to set a date or anything.
We could. I'm just trying to think ahead. Maybe we
Right.
could just try to plan on something. Should we
But-
just plan on having a meeting next Tuesday?
Yeah,
And,
why
and,
not?
and if nothing else, yes, ma'am?
So I would prefer to wait to see when I hear from the governor. If that's Monday or Tuesday, then we can have a meeting on Wednesday, give us staff some time to look in what the governor's doing.
Why don't we say we're going to have a meeting next week? We'll
Right.
confirm the date. And this item that we were just talking about, it'll be on the agenda. We'd welcome input from staff on any recommendations on
Yep.
any local policy changes. So, is that,
So,
So the hotel
yeah,
discussion will be on there.
the hotel discussion will be next week. I would really like to talk about that tonight, because it seems like there are a majority looking at it, and we're the only county that's like this. And, I mean, these people's got to go to work. And the thing is, I guess one of my questions is, County Manager, does the staff make the decision if we go 100%, or commissioners make that decision?
Sir, our job is to make recommendations.
Exactly, but I'd heard through out there, the staff talking, that we want to look at more data before we decide. So I was thinking maybe the staff is making the decisions, what I heard, instead of
they make recommendations.
that. Well, yes, and I know they make recommendations. Like I said, we would rather look at everything before we make a decision. I would like to make a decision that
Okay.
we talk about this tonight.
I appreciate that. It would have to be a consensus to add it to the agenda. I'm not supportive of that myself. So there's not a consensus to make that decision tonight, but I would be happy to take it up next week. I'd like for the staff to think about the discussion we've had and come back and make a recommendation on that point. But I'm not supportive of it tonight. I'd like,
Okay.
I think we need
Can
to
we take a vote on it?
Well, it has to, under our rules.
Exactly, it does, but I'd like to know where we stand.
Let me just clarify.
Okay.
Our process, our adopted county rules require that any new item to be added to the formal agenda must be done so by consensus, and there's not.
And by consensus is voting.
That means it has to be 7-0.
It has to be 7-0.
But you voiced your opinion and made a decision before.
Well, it only takes
Okay.
one, and I think I'm one of them. So
Yeah,
even
you're
if
the
everybody else
chairman.
disagrees with me, that's just where I'm at, okay?
Okay.
So
I disagree.
I appreciate that. I appreciate that. All right, we have only a few minutes before we start our next meeting. Are there any other, oh, Jasmine, you had another
I'll
item.
make
you were
it
doing.
incredibly quick. And just wanted to, first of all, just thank Commissioner Belcher for the work he's been doing over the years, working with the litigation team on the opioid litigation, and also Michael Frew and Brandon Freeman are from the legal department. I've had the opportunity to sit on a working group that NCACC has convened. It's called the 5x5x5. It's 5 county commissioners, 5 county managers, and 5 county attorneys from across the state. Some of whom are involved in the multi-district litigation, some of whom are not. The goal is to see if there can be sort of a shared voice coming from North Carolina counties around the terms of a settlement. And this NCACC is in dialogue with the Attorney General's office to see if there can be a shared voice from both the state and county level perspective. So I just wanted to just share a quick update about that. There's seem to be some rumblings that this may be moving forward quickly based on some developments with Purdue specifically in their bankruptcy process. There also are rumblings that it's moving forward slowly. But the goal of that NCACC set out in convening this group, and it's counties like Burke and Guilford and Dare counties, us, is to see if there can sort of be one voice around specifically the way settlement funds would be allocated in sort of a global settlement that would address all the litigation that's on the table with the same defendants, basically. And the point of some of the points of discussion have been the Attorney General's office perspective that a greater allocation should go to the state, and county perspective that a greater allocation should go, you guessed it, to counties.
Man?
Hmm?
I said amen.
Amen, yeah. And whether or not there should be an entity that would have some basically oversight of how funds were used for both abatement purposes and whether they could be used to address past costs. So I just wanted to make sure that our commission is sort of aware of that dialogue. If anyone wants to talk further, just let me know. And I would be happy to share more updates as the discussions with the AG's office continues. And the legal team that is representing Buncombe County, among many other counties, has been sort of offering some updates and counsel about settlements happening in places like Ohio and Texas during this period. Thank you. That's
So I'm glad to hear you say something, Commissioner, because I've been on a gag order for a few years, you know, on the, I guess we did this 2 years ago. But there is some it's interesting perspective. You mentioned the AG, and there is some, you know, friction between those that are making the lawsuit, like a county, and then the different states having different positions. And because it's going to be so much, you know, money that, you know, will be used, I think, for a lot of good. It's thanks for your report. It'd be good to hear at some point in time a county report on the, you know, our lawsuit at some point in time. You know, doesn't have to be any time soon, but anyhow, thank you.
Hey, before we adjourn this meeting, could we just talk for just a minute about public comment at the next meeting, just so we make sure we're kind of clear about the procedure. So, Mr. Presley, I appreciate you filling in for me last week.
Yeah, you
did a great job. So thank you.
Yeah, everything was 6-0.
All right. I just need to get out of the way. So there was a decision made to take public comment in person on the budget, for the budget hearing. So we'll do that tonight, right? So folks who are here, Ms. Pender, we just maybe briefly describe the protocol we have for that.
So what we have, if you've seen outside, we have marked off 6 feet. We have the seats in here 6 feet. So what we would allow staff to fill this room, or the public to fill this room first, and then we'll bring overflow in and keep 6 feet. They must wear a mask. We provide a mask to the public as they come in to the building, and then they can take it off to speak and leave. But we do have the 6 feet marks off outside, and they can come in, and we'll keep this room. You must have a seat in this room. That's how we can maintain 6 feet. And then we'll bring them in, and there's one way in and one way out of the room here for us to maintain that.
Okay. And the decision was the public comments on the budget, not on other items on the agenda. Is that correct?
That's what was discussed last meeting. At the last meeting, we had no idea there'll be other
And on the other items, we're going to continue to do public comment as we have. So if people have emailed comments, they'll be read. If people have left voicemails, we'll listen to some of those. Is that correct?
Yes, sir.
Okay.
And I believe you have it there. We have so many that I think if we added up 3 minutes, would almost be 5 or 6 hours if we listen to all. So there'll have to be some point you will say enough.
Okay. Could we just talk for just a second about how long we want to do this, right? Because it's 5 or 6 hours. So I'm open to ideas. I mean, my suggestion would be, and I assume most of them are on the monuments issue, or is it mostly any other items that got a lot of comments?
There were some on the budget items, but
we'll hear from those folks,
from those,
right?
And there were some that came mail in as well from the budget. And then there were some general comments as well.
Okay.
For the public comment at the end of the meeting.
Okay. So I'm open to ideas. My suggestion would be we take up to an hour for public comments on the monuments resolution. And in that anybody we don't get to, we would publish those comments so that they become part of the record as well. So that's one suggestion. What are other people's thoughts?
I like the 1 hour because the 5 hour could be hard.
Right.
Waffle House closes at 3 in the afternoon now. So, my suggestion is we know the monument, yay and nay, tear it down or replace it or whatever, is just go through there and how many's for it, how many's against it. I just don't think that's really telling the story of what everyone's talking about. You know, there's 250,000 people here and we got 600 emails, I think. So if it's 400, 200, and just list who was for, who's against, and put it on the website, because it's going to be the same story over and over and over again.
If you can pick up the sentiment, the basic sentiment.
Yes.
That comes from those that have, like, you're probably going to end that, you're probably going to have 3 or 4 different positions. You know, pick that up and make sure that is, everybody hears it.
Is everybody okay with, let's plan for an hour. We'll do 30 minutes we'll read emails that have been submitted, and we'll do 30 minutes of the voicemails that have come in. Is that workable, Ms. Pender? And Mr. Joyner? Anybody's?
Yeah. Yes, sir.
Got
I'm
these,
looking at
okay.
the clerk. The clerk was the one that actually created all of this, so I was looking to him to see if
Is
he
that a
has a
workable
comment.
approach, approximately? Okay, thank you.
Just
All
a
right.
quick point of clarification. If, for messages that were specific to the budget, is there a way to hear those as part of our public hearing on the budget?
As part of it.
Yes, sir. There were emails, and we actually have those that you could read.
Okay,
For
excellent.
those, and then
So
anybody wants to
the public
speak.
hearing on the budget will include whoever's here in person plus voicemail and email on the budget.
Yes.
Okay, great. Thank you.
One other point on the monuments resolution, and Mr. Frew or Mr. Joyner, I'm not sure who I'm pointing to here. There was a very slight difference in language on the resolution that the city council passed. Do you have hard copies of that, Mr. Frew?
Yes.
Okay. All right. Could you share those with all the commissioners? Yeah.
So we probably need to be having that discussion in the.
No, so I just wanted to bring it to your attention. There'll be a hard copy of that to look at. It's literally, I think, one sentence or two that was different than the originally drafted resolution. So I just wanted to alert everyone to that.
Okay, so you're doing 1 hour?
For the monuments resolution, yeah.
Right.
Public comments.
So how will you do that? Take as many positive as they are negatives? I mean, that's the only way I think to be fair.
For an hour, probably.
Yeah.
So I can give some quick input. I have 32 recordings of them. That's when they stopped sending me to them. And they were all in order when we got them. And the majority of the first half was kind of feeling one way, and the majority of the second half was feeling another way. So I don't sort of meet that criteria.
Okay. Give them 3 hours to sort it out, right?
Okay. I think that's everything. So let's adjourn this meeting, and let's take at least a short break before we come back. Why don't we come back in 10 minutes and we'll get started?
Yeah.